We're presenting a deeper look at the patient characteristics in the patients that were enrolled in the Catalyst trial. So these were people with advanced or difficult to manage type 2 diabetes, basically people who were on greater than 3 glucose lowering medications. And there were other alternative criteria, but their A1C was between 7.5% and 11.5%. And one of the alternative criteria is we're having comorbidities and evidence of difficult to control blood pressure. So again, people that aren't like easily controlled with one medicine, not controlled despite several medicines, glucose and or blood pressure with or without comorbidities. So then we did a 1 milligram overnight dexamethasone suppression test on all of them, and we found that a quarter of them failed the dexamethasone suppression test, indicating some form of hypercortisolemia. And when I say failed conventionally is 1.8 micrograms per deciliter or higher of the serum cortisol after the 1 milligram test. But that's 50 nanomoles per liter. That's a sort of nice round number that was developed by consensus guidelines. If you take really truly normal people, normally their cortisol suppresses to like 0. And a couple of groups have looked at what the normal range is for dexamethasone suppression tests in people who you do this on who are really low suspicion of hypercortisolism. It should be really otherwise normal. And it turns out that the +2 standard deviation is about 1.2 micrograms per deciliter. So that begs the question, well, what are these people between 1.2 and 1.8 like? So we looked at this. So we compared the people whose cortisol after dexamethasone was less than 1.2, 1.2 to 1.8, or greater than 1.8. And there was a gradual worsening of disease criteria, disease control, comorbidities, and so on as you went from one group to the next group to the highest group. And in many ways, the 1.2 to 1.8 group looked more like the 1.8 group than the less than 1.2 group. So now in the part 2 of this study, the people who were over 1.8 were randomized to mifepristone or placebo. And there was a salutary response on glucose for the mifepristone arm, A1C lowering about 1.5%, 1.4, 1.5%, and about 1.3% relative to placebo. Now, we didn't test the 1.2 to 1.8 people. We didn't treat them. So it now sort of says, what would happen if we treated those people? Now, you could also take this one step further and say, well, what would happen if we treated the people who were less than 1.2? And I think these are the sort of questions that are now things that we need to address. So that's what my presentation is about, and that's sort of the global implications of that. Well, I think that they're already on the list that they should be suspected of having a secondary cause, such as hypercortisolemia. There are others, pheochromocytomas can cause hyperglycemia and so on, but it just reinforces the guidelines that are already there, but I think are not commonly carried out, even in endocrinologist practices. Not really. Some of these people wound up having adrenal adenomas and probably have ACTH-independent neoplastic hypercortisolism. But a lot of them, it's probably what we would call non-neoplastic hypercortisolemia that's due to intercurrent illness and stress, which basically the diabetes itself could be considered that. And they all responded. So I think that's it's sort of comforting, but vexing in that it's the test is an easy way to find people who should respond well But the reason they respond and the underlying reason that their cortisol doesn't suppress completely doesn't seem to matter. So that's a little different than the way we've normally thought about. Normally, we think about only treating neoplastic hypercortisolemia, but if there's a benefit from cortisol-directed therapy for even people with non-neoplastic hypercortisolemia, then maybe the cortisol response is a maladaptive response to the chronic stress that is perpetuating the situation. And I think the psychiatrists have thought about this for mental illness for a long time. I think we need to start thinking about this more for other medical conditions. Well, perhaps, but I think again, I think one of the notes is, when you're using the usual drugs, patient is not responding, you should think of secondary causes. Cortisol is very likely character. We already do the same for hypertension and aldosterone. It's kind of well known that if people are not responding to the usual drugs, you screen them for primary aldosteronism. There is an enriched population. Even if they don't meet classic criteria, they respond very well to MRA antagonists like spironolactone and eplerenone. So now the difference is that spironolactone and eplerenone are widely available. We had them for years, very inexpensive. We know the side effect profile. Many people are comfortable using them. That's not so much true for the cortisol-directed therapies. They've generally been sort of boutique drugs that only a few endocrinologists use who specialize in Cushing's and pituitary centers, adrenal centers. So I think that's a barrier to implementation, is the comfort level of the average endocrinologist, the average internist in using cortisol-directed therapy. So there's a ways to go with this. But I think there's no excuse for not thinking about secondary causes. I'll put it that way. And this is just, there's many other smaller papers and studies that have found this. This is just a very large paper that kind of did it in a very comprehensive way, a large study. So it just reinforces what we kind of already knew. Well, I think what I just said is that you shouldn't be afraid to screen for secondary causes of hypertension and diabetes. Certainly, well, the new primary aldosteronism guidelines are going to be released on Tuesday morning. And, they're also going to emphasize broader screening and stuff. So I think, just when the usual things don't work, don't keep banging your head against the wall. Think about secondary causes. And cortisol and aldosterone are two of the first things you should be thinking of.